Thank you, Emily, for that kind introduction. I just want to confirm you can see and hear me. And you have is my presentation showing up? The title slide? Wonderful.
Yes.
I just want to start off by saying how much I enjoyed this first hour. And if Sarah, Sarai, and Mary are still on, I want to thank them for sharing their lived experiences. And a lot of what I'm going to talk about is derived from trying to listen to the experiences of the parents of the kids that I look after. And that really is what this talk is about. It's asking the question, whose life is it anyway? And making a difference, and to ask the question, are we? Greetings from Toronto in Canada, where spring has actually sprung. It's been relatively warm here, and today was a bit of a rainy day, perhaps like Seattle's used to. But experience has taught us that it's a little too soon to celebrate. It may be after March 21st, but I'm not sure we've given up on winter yet. But certainly this last week has been a wonderful appetizer. So I am based at the Hospital for Sick Children in the city, and at the Holland Bloorview Children's Rehabilitation Hospital, which is a children's rehab hospital also in Toronto, and we're closely affiliated, where I look after the kids with cerebral palsy. That's the outpatient facility that we see those children, and they have an inpatient facility as well for their post-op rehab and so on. And it's an amazing institution that I'm very fortunate to be part of. I want to start by acknowledging why I'm here. This is really a privilege and an honor to have been invited to speak on this occasion. I didn't have the pleasure of knowing Dr. Duncan. From what little I've heard about him, and from what you said and shared, Emily, he sounds like an amazing man that I wish I had known, and someone who I wish I would be able to emulate. Thank you so much for this invitation. It's a real honor to do this. However, I have to confess, I am, very disappointed. I'm sitting in my office here in Toronto, and I would have so much preferred seeing you all in person in Seattle. This is the best I can do. You see this? We actually have a Starbucks in the lobby of Sick Kids, and I can indulge my one coffee a day from them. It keeps us happy. So that's my Seattle connection for the day. So I'm giving two talks today. This first part is really about defining outcomes that matter. What really is meaningful to children with cerebral palsy and to their parents. I'm going to introduce the ICF model that I think was earlier introduced by, and mentioned. I will talk about that. I'd like to define the concepts of quality of life and health-related quality of life, and talk about the challenges of measuring these concepts in children with cerebral palsy. I want to introduce you to the priority framework, which is what we've used to better understand what's important to this population, and using that framework then to quantify outcomes or develop measures that can quantify these outcomes. And if they're measurements, then they have to be reliable, they have to be valid and responsive. And in the two parts, in the two talks that I'm going to give, I'm going to share the two examples of the work that we've done arising from this priority framework. And in this part one, I'm going to focus on the CP child. And although, I'm trying to make sure that my talk is not too technical. I would like to think that some of the language that I use is accessible and is also speaking to parents of children with cerebral palsy, because that's the source of this information. And although this talk is targeted at the providers and clinicians of various disciplines, it is really also meant to illustrate that we're listening to the voices of parents with children with cerebral palsy. So my research background, it can be summed up with these 3 points. You know, very early in my career, it became apparent to me that I really wanted to understand whether I was making a difference in a meaningful way to my parents, to the parents of the children that I have the good fortune to work with. And it also became clear that in order to know whether I'm making a difference, I need to understand, what's important to them and their parents. And understanding their priorities helps you define what goals and priorities parents might have and can influence and support decision making. And it's a real deep understanding of these priorities that's necessary to embed within the outcome measures that we use. We have to make sure that those outcome measures actually capture these priorities. And then once we develop them, we can then use these measures in research and clinical trials and of different kinds to evaluate whether treatment A is better than treatment B, whether treatment C is actually making a difference to the lives of the children that we're offering these complicated, resource-intensive interventions. So to start, I'd like to introduce you to 2 people. Jill is 12 years old. She has CP. She functions at GMSS level 5, which means she is reliant on her mother for all her activities of daily living and for her care. She's nonverbal, but she's able to communicate very effectively by her facial emotions and her gestures, and for the most part is a very happy child. She has a seizure disorder that's under control. She's fed by a G-tube. She's had pneumonias over the course of her childhood, some of them which hospitalize her. She's not toilet trained. She's a full-time user of a wheelchair, which then allows her to go outside. She relies, like I said, on a mother for all her activities of daily living. She's got a variety of musculoskeletal problems that are beginning to have an impact on her life. David is also 12 years old. He's a twin with CP. He functions at a GMSS level 3, which means he's able to walk. He uses canes at home, but outdoors for any meaningful distances, he needs to use a walker for support. His parents are particularly proud that he's not using a wheelchair, and I'll get back to that. But he's been less active over the last year, and his parents are very keen and want him to, walk better. And you'll get to meet David again in my second talk. Evidence-based medicine is sort of a phrase that we're all very familiar with, and this has been defined in many ways. And David Sackett, who was one of the pioneering developers of this concept, defined it as such. It's the very deliberate or conscientious, explicit and judicious use of the current best evidence in making decisions about the care of individual patients. And that definition, implicit in it, are 3 pillars. The first one we're all familiar with, that evidence to inform decisions should come from well-done research, from high-quality, rigorous research like clinical trials, etc. There is allowance then to incorporate the clinician's own perspective. So an individual clinician has her or his expertise and experience that's acquired from their practice, and that is allowed to influence or contextualize the evidence from research to then inform their decision making. A third pillar, which is often neglected or only paid lip service to, is the importance of taking into consideration patient preferences. And by patient, I'm referring to the parent and the family as well. What are their priorities? What is it that really matters to them? And it is crucial to incorporate this in our decision making, and evidence-based medicine explicitly requires that, even though we often forget to do that part. Over the last 2 or 3 decades, there's been an evolution in the concept of patient or family-centered care. There's a growing interest in acknowledging and, the importance of the patient's perspectives. The outcomes research movement that evolved in the late 80s and 90s by pioneers like Goldberg defined this as to sort out what works in medicine and to learn how to make clinical decisions that reflect more truly the needs and wants of individual patients. And if we believe that, then the effectiveness of our interventions, the success, does it really, are these interventions actually successful? They should be judged using meaningful outcome measures that reflect the goals and expectations of individual patients. In other words, if an intervention is successful, we need to make that judgment based on how patients and parents consider that success. So what are outcomes? Well, outcomes are what happens after an intervention. They can be desirable, the things that you want to happen. They can be undesirable, and we heard some examples of that this morning that I believe Sarah shared with us. These are complications, these are adverse events, are often unexpected, sometimes expected but only transient, and we're assuming that that's a price worth paying, but not always. These can be early, they can be in the short term, and there is the long-term outcomes. I think we can all agree that a successful outcome is one that achieves the goal for which that intervention or that treatment was intended. And that goal might be prophylactic or preventative, to prevent something bad from happening in the future, or reactive, to address a particular problem that the person is experiencing right now. But whose goals are we talking about? Is it the child's? Is it the parents, or both? Is it the clinicians? Or is there a societal perspective here as well? And outcomes measurement is really the science of measuring effectiveness. It's the science of measuring the definition of better. Are we making a difference? For the clinical research amongst us or in the audience, you might have heard of the PICO framework, where P stands for the patient population of interest, who've got a specific condition or a disorder that we are trying to do some research on to find out if a particular intervention or a treatment is successful or not for that particular condition. That's the I, or the intervention of interest. There's the C, which is the control group. So the same set of patients who receive an intervention should be compared to another group of patients who don't receive that same intervention, or receive another intervention, or no treatment at all, to see if the first intervention is actually doing better than no treatment or some other treatment. But then again, making a judgment about whether it made a difference or not requires us to actually have an outcome measure. And we take this often for granted, and we'll talk more about that. And this is what we mean by defining better. Michael Goldberg, that some of you might know quite well, is based now in Seattle, a pediatric orthopedic surgeon, a pioneer and a visionary who was way ahead of his time when he came up with his model of outcomes that he published in the early 90s. And I have learned a lot from this particular model. He reminded us as orthopedic surgeons to think of outcomes beyond just the technical outcome. The technical outcome is sort of the immediate target of the intervention. There is high muscle tone or spasticity. Well, you inject Botox to reduce that spasticity, and you can measure that difference. You can make a weaker muscle stronger. You can make a short or contracted muscle longer. If there's a bony deformity, you can align that. If there's a spinal deformity, you can straighten that. If there's a joint that's dislocated, you can put that hip back in place. But he reminded us that we need to distinguish that from what he called a functional outcome, which is the reason for why we're doing this intervention in the first place. And that the technical outcome is really a means to an end. And that end, or that functional outcome, might be to improve physical function, it might be to relieve pain, it may be to make care easier, it may be to reduce tripping and falling, or improve the physical appearance of somebody's gait. Those are the ultimate reasons for which we are doing this intervention. He also talked about the concept of patient satisfaction and ultimately about cost effectiveness. And these last three things were things that we never talked about. We were very good at measuring X-rays. You know, there's an angle, an abnormal angle that we straightened out, and we patted ourselves on the back. But that clearly is meaningless to the child or to the parents. The concept of patient satisfaction is quite a popular one, and the issue is, you know, are they happy or not with the treatment that they received, and did achieve the outcome that they were hoping to achieve? The problem with satisfaction is that most patients are satisfied, often even when the intervention was less than fully successful. And there are many reasons for this, not least because there is a tendency to think that without it, it could have been even worse. There are ways to explain that, you know, even though it was unsuccessful, a lot of care was taken in doing it, and people don't want to blame. And so it turns out that measuring people's satisfaction can be quite misleading, and it's not a very satisfactory measure of a good outcome. When someone is not satisfied, that is a red flag and important to pay attention to. But just because someone's satisfied is really not enough. The International Classification of Function, Disability, and Health, the ICF model that I think Kelly might have introduced in her introductory remarks when she was talking about Bill Duncan. This was introduced by the World Health Organization, and it has at the top a particular condition, in this case cerebral palsy, that has an impact on what's called the body function, the structure, and that explains what's happening biologically, if you will. That cerebral palsy is ultimately some problem or insult that occurred to the brain that then creates problems with muscle tone and contractures and bony deformities. And those are things that we call impairments at the level of the body function structure. However, these impairments can then have an impact on the child's activities and can limit them. Those activities are things like walking or running or jumping. And even those activities have a purpose. The reason why we walk is to get from A to B, so that when we get to B, we can do something that we want to do at B, whether that's going to school or playing with our friends, and we call that participation. So just because there's an impairment at the level of the body function structure, that may or may not result in activity limitations, and the activity limitations may or may not result in a restriction of participation. And even if it does, that does not mean that we need to address the impairments in order to improve participation, because we can take advantage of environmental factors and personal factors that can still have an impact on what's meaningful, which is in this part of the framework, the activities and participation part. Our interventions, of course, are directed here, and that's fine. But the reasons why we do this here is because we make the assumption that we're then making a difference to the lives of children in the areas of activities and participation. So take cerebral palsy, for example. At the level of body function structure, you can have spasticity or contractures and bony deformities that are secondary to that abnormality that's occurred in the brain. This can affect walking or running, which might have an impact on the child's ability to participate in perhaps sports, or later on in life in relationships or employment, or and children as attending school. And yet you don't have to walk or run to be able to go to school or participate in sports, or for that matter, to be employed or have a relationship. And we need to think much more holistically about these things and not focus merely on how we can make changes here in order to achieve goals that are more important over here. Notice that in that framework, there's no mention of quality of life, but the assumption is that enhancing individuals' activities and participation is what contributes to quality of life, which is the individual's perceptions of their position in life in the context of the culture and value systems in which they live, and in relation to their goals, their expectations, standards, and concerns. This is the World Health Organization definition. There are many definitions, and this is one that I quite like. And it's an individual person's perception of their own well-being. So I'm going to stop right now and ask all of you to sort of reflect on this question for about 30 seconds. Now, if we were in person and you were all sitting close together without masks and safely able to chat with each other, we would get you to share these thoughts, and in an audience, I would ask you to shout out what you were going to say. Now, I don't have access to the chat, but maybe you can share those in the chat. That may not be a very efficient way to do it, but make a list for yourself. And I'm going to give you another 20 or 30 seconds to do this. And you can all do this individually. So make what are the things in your life that contributes to your quality of life? What makes you happy as an individual? Okay, I'm going to guess that if we were all together, one or more of your things that you mentioned would fit in any of these places, and there would be a big other here. So some of you probably said, your family, your social life, your work life. Someone might mention health. Often, health is not mentioned until, quite a way down. And I'll explain why. But if you really thought about it, it might be, food and drink and being able to travel, your financial security, participating or watching sports and recreation, exposure to arts and culture, education, technology, where you live, the government of the day, whether you've got access to public and civic services, safety and security, your personal and civil rights, whether there's a war going on where you live, your freedoms, your ability to practice your faith, having access to justice and equality, the economy, your climate, your environment, where you live. And as a pediatric orthopedic surgeon, I think we need to acknowledge that at best, I might make a small impact in the domain of health from time to time. And that's just a very, very small part of this much, 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 much bigger picture of what contributes to quality of life. Your work life may not be so important to you when everything is going well. But if you are at risk of losing your job in the middle of a pandemic, that might have a huge impact on your quality of life because of its impact on your financial security. Your health may be fine because you're taking it for granted until maybe you sprain your ankle or your child has a serious illness that requires a major operation. And then that takes precedence. The point is that quality of life is broad and it's multidimensional and it's individual. If I'd asked you to rank your priorities, your rank order list would be very different from mine, as it should be, because these are personal, which means they have to be self-reported. I cannot make judgments about your quality of life or about your child's quality of life. That's for you to judge for yourself and for your child to know of themselves. And this is enshrined in the UN Convention on Rights of Persons with Disability, and even for children. Disabled children have a right to express their views, even if we may not have access to their views. We can only measure these indirectly through its domains, and it's very subjective. And we need to recognize it's dynamic and contextual. What do I mean by that? What's important to you today may be less important to you next week. And 6 months from now and a year from now, there may be something that's far more important, and what was important for you now becomes less important. So it really depends on the context and the times that we're living in. I think can give us lots of examples that illustrate that. Now, health-related quality of life is just a small subset of quality of life, and it's the health-related factors that contribute towards the goodness and meaning of life and how we perceive one's ability to fulfill certain roles. And that health is not just physical health, but it's mental, emotional health, and it's even social health. So it's much more holistic than just physical health that we sometimes tend to think about. We need to also reflect on this statement. What's good for quality of life might not always be healthy. Okay. There are college-going students who wanted to celebrate spring break, who flocked to Miami at considerable risk to themselves and to others, because that's what they thought they needed for their current quality of life. It's hard to blame them, but that's not healthy, nor should that be encouraged. Similarly, what's good for health, like this needle, or even a mask, may not always be good for our quality of life. Okay, but still may be necessary. So why are these concepts important for cerebral palsy? Well, cerebral palsy collectively are the most common cause for chronic physical disability in children. And of course, its impact is far more than physical. And it's lifelong and affects not only the child or the person with cerebral palsy, but to the parents and the caregivers, to the family, arguably to the healthcare system and to society at large, with interactions. And we've seen some examples of those, some good and some not so good. Health-related quality of life in cerebral palsy is difficult to conceptualize and to measure. Once again, quality of life, remember I said, is personal, it's dynamic and contextual, it changes over time and circumstances. And we've got to ask ourselves, whose life is it anyway? What would Jill want? But I simply don't have access to Jill's perspective. Now, Jill can convey what makes her happy, and someone like Jill might even be able to communicate that with a communication device, but there are many children like Jill whose cognitive impairments and communication challenges currently make it impossible for me to ever know what's really important or what her or his perspective might be. And under those circumstances, we have no choice but to rely then on the next best perspective, which is Jill's mother, who knows her best. But the moment we do that, we have to acknowledge that that is a proxy which mixes up different things. Not that they're not important, but it does take it away from what maybe we're really interested in, which is Jill's quality of life, or what contributes to Jill's quality of life. And that is, it's merely a perception of Jill's quality of life, but Jill's mother's perception of that is far better than mine. It's also the perception of the burden or the ease of taking care of Jill that influences Jill's mother's perception of her quality of life. And mixed up with that is also Jill's own mother's quality of life and how it's impacted by Jill's life and Jill's quality of life. And all of these things are impossible to disentangle. And that's okay, as long as we acknowledge that and recognize that that is still very important information that we ought to know. Reflecting on what Jill's going through right now, she's got gastrointestinal problems of vomiting and reflux. She's got respiratory problems that get her hospitalized frequently. She's sleeping poorly at night, needs constant repositioning. She's finding it difficult to sit for extended periods of time, and that is her way to interact with the world. Her mom is single, divorced, and finding it increasingly difficult to clean, bathe, and change her and move her about and transport her. Jill loves to swim and be taken for walks. However, the local public pool is only open in the summer, and where they live, the snow removal services are mediocre at best, and that limits how far they can go outside the house in winter with her wheelchair. Now, children like Jill are subject to major interventions. There are neurosurgical procedures to address hypertonia, and we heard about from Sarah earlier today about intrathecal baclofen pumps, for example, orthopedic procedures to put hips back in place, spinal procedures to straighten the spine out, to correction of contractures. These are major interventions that are resource intensive and expensive with a high rate of complications. Why are we doing these? What's important? Well, for someone like Jill, it is in one of these four areas. It's either to relieve pain if there's pain, or to prevent pain if we think there's a high chance that she's going to get pain in the future. It's to facilitate or make caregiving easier. It's to preserve or improve health, and it's to preserve or improve quality of life. If the intervention that we are recommending does not address at least one or more or some combination of these things, we've got to ask ourselves, are we making a difference? What we tend to measure are things that are measurable. There's tight muscles, we can reduce the tone and measure the muscles being looser. We can measure the range of motion. We can look at radiographs that show that the hip that was previously out is now back in place. We can measure a crooked spine that now is straight. What we really need is a measure that incorporates what's important, and that is these things. Well, about 18 years ago, we asked this question, what are the outcome measures for children like Jill? We found that there were some generic measures that measure health status and what purported to be quality of life, but many of those measures were not very good, and parents who completed them were actually upset because a lot of the items were inappropriate. They simply didn't apply to children like Jill. There are some cerebral palsy condition-specific measures, but they're also not suitable for children with severe disabilities because, once again, a child like David, who's able to walk, his goals and priorities are completely different from those of a child like Jill. And having one measure that tries to span that entire spectrum of cerebral palsy, which is very, very variable and heterogeneous, is doing a disservice to both ends of that spectrum. There are some measures that take a societal perspective, and I will give you an example about that in a few minutes. But early on, a parent of a child that I look after shared this with me. She said, "No one asks me what might make life better for all of us." And that was eye-opening because we realized that we needed to talk to parents and find out the answer to that question. We need to determine what their priorities are. So what are the parents' experience of caring for a child with severe cerebral palsy? Answering that question will give us a deeper understanding of their priorities, including their concerns, needs, desires, and expectations, both for the current as well as the present as well as the future, and shed some light and give us some insight that can help inform decisions about the kinds of interventions that can improve the quality of life for the child, the caregiver, and for the family at large. And this realization, along with some of the thesis work that I'd done prior to starting my practice, led us to the development of the priority framework of outcomes evaluation. In the middle, you have the condition, in this case, cerebral palsy. And let's be even more specific. Let's think about children like Jill, who are reliant on a wheelchair for their mobility and a caregiver or a parent for all their activities of daily living. What is the lived experience of the parent or the caregiver living with a child or looking after a child with that severe cerebral palsy? What are their priorities? What are their concerns, desires, needs, and expectations? And what are their goals that arise from this lived experience? but whose perspective are we trying to tackle and to find out? There is a child whose perspective I may not be able to access, except for some few circumstances, and there are some exceptions, and in which case we absolutely must do that. There's the parent's perspective, there is the larger family's perspective, and there are other clinicians, healthcare providers, and a societal perspective. All of these have very different perspectives, some of which may be overlapping, but some of these may be converging or even divergent. And it's important to recognize that there are different perspectives. Only an understanding of these priorities allows us then to think about interventions to address these priorities and goals. And by our interventions, I think we need to stop limiting our thinking to just medical and surgical treatments or therapies. Of course, those are important and are absolutely essential to consider, but we need to think of them in addition to other kinds of interventions like legislation and policies, programs and services, design, technologies, architecture, devices and equipment that can all have a positive impact on priorities and goals, either complementing or instead of, or even better than some of our medical or surgical treatments might have. When we come up with these interventions, we need to know whether they work. And the way we would assess that are by various forms of evaluations. And if it's a clinical treatments, then we have clinical trials and cohort studies, the kinds of clinical research that we are used to doing. And to make judgments about whether these interventions are addressing these priorities, we have to measure the outcome. So the outcome measure is that measurement tool that defines whether or not the intervention achieved the goals for which that intervention was intended. And if that is the case, the outcome measure that we use must embed those priorities and goals within them when they are being developed. So this triangular framework is what has influenced our thinking, and everything goes back to a deeper understanding of patient or parental priorities and goals that arise or come from the lived experience of looking after a child with severe cerebral palsy, or from that lived experience of living with a child with severe cerebral palsy. So now that 18 years ago, we embarked on this qualitative project where a social worker on our team visited the homes of children, essentially to be a fly on the wall, if you will. Spent 2 to 3 hours in the day to observe what a typical day might be like. We left the family with a camera to take photographs of the good, the bad, the ugly, positive and the negative over the next 12 weeks, and to print those photographs or send the camera back to us where we print the photographs and share them back with the families. We went back to the homes and shared the photographs with them and further interviewed based on the observations on the first visit, but also what they were trying to convey to us with those photographs. These transcripts were then recorded and analyzed by a multidisciplinary team. And we identified themes from these photos and interviews using what's called a phenomenological approach, looking at the lived experience of the caregivers, and in a few instances of the person with cerebral palsy as well, to try and define the concerns, needs, desires, and expectations. Those are the priorities, and what impact these had on the quality of life. We purposefully chose a wide age spectrum from 8 to almost 19, with GMS level 4s and 5s, both boys and girls. We were and tried to ensure capturing both single and two-parent situations, families where there was a sibling or no sibling. We tried to capture the socioeconomic spectrum. We tried to ensure that we had families in urban, suburban, and rural locations, in the kind of how they lived, either in an independent house or an apartment or a townhouse, the time of the day when we visited them, and the week, sometimes during the day, sometimes in the evening time, whether it was during school time or holidays, whether it was in the winter, spring, summer, or fall, all of which can have an impact on the lives of children. And I'm going to summarize this very quickly to say that we identified these 8 major domains within which we identified promoters and barriers that had an impact on the quality of life. There were child factors, there were parental health factors, and not just physical health, but mental health, emotional health, psychological health, and economic health. There was parenting and family life. Supports and services was huge. There were attitudes, outlooks, and feelings. There were a variety of coping strategies. There was the environment where they lived, the climate, the geography, the terrain, and life events, a wild card that I'd be happy to share in the Q&A. During the course of the 3 years that we did this study, one of the children in the group that we interviewed passed away. One of the a set of parents got divorced. One of the single mothers got remarried. A grandmother who was an important caregiver was hospitalized. A father died. And my co-principal investigator, Bev Antley, who was instrumental in designing this study, was tragically killed in a road traffic accident. So things happen which have a huge impact on the life of these children. And they're all interconnected and closely related. And from this work, we spawned the Caregiver Priorities and a Child Health Index of Life with Disabilities, the CP-Child, where CP is not cerebral palsy, but caregiver priorities. And I think this morning's wonderful interviews illustrate the importance of incorporating caregiver priorities. The CP-Child Questionnaire was then derived from these interviews and from interviews with healthcare professionals and from the literature, has 37 items across 6 domains. It's scored from 0 to 100 for a total score, and the 6 domain scores, which we'll get into. These are the domains or the areas that it captures. Personal care and activities of daily living, of which there are 9 items. Positioning, transferring, and mobility, that there are 8 items. Comfort, emotions, and behavior. Communication, social interaction. Health and health-related issues. And a single item on overall quality of life. And there's a 7th section that asks parents to report how each item in the main body of the questionnaire is, how much of a contribution it has to the child's quality of life. So the caregivers rated the importance of each item's contribution to their child's quality of life on a scale of 0 to 5, from least important to most important. And the reason we did this is this was a way for us to ensure that when we administered the questionnaire, that parents were telling us that these items were indeed important to them. And if they were, we would retain them in the questionnaire, whereas less important items could be dropped. So in the development of the questionnaire, this was an important strategy. We also wanted to acknowledge that not all items were going to be equally important to all parents and caregivers, that some items may be more important to others, in which case maybe we should weight the scoring for each item based on how important that item was for a particular caregiver. And the bottom line is, while it was true that we found that some items were more important than others for some parents, trying to weight the score based on that importance was not necessary because there was a very close correlation with the scores generated in the usual way compared to scores generated by weighting it based on these importance ratings. What we did find out that here is a graph that shows all the 37 of the items of the questionnaire and how important they were on a scale of 0 to 5, where 2 was slightly important. You can see the average importance was above that threshold in every instance. That justified that the content was relevant and important to caregivers. Any measurement tool needs to have certain properties of a good measurement tool. So when things don't change, it should give you the same answer. So we tested this for what's called the test-retest reliability 2 weeks apart. So we administered the questionnaire 2 weeks apart and asked parents that within that 2-week interval, had the child changed? And if they had not changed, we analyzed them to see how much of a difference there was in scores. And we found the absolute mean difference of about 4 points on a scale of 0 to 100. And here are the statistical tests that we did, called the Intraclass correlation coefficient, which was a very respectable in 0.9 for the total score, and in the high 0.7s to 0.9 for each of the domain scores, showing that the reliability was really excellent for the questionnaire. We tested the internal consistency, which just shows how well the items correlate with each other within each of the domains, which is another important measurement property, and that was also very high. We looked at the distribution of the scores, and we found that in a large group of kids whose caregivers completed the questionnaire, there was a range of scores for these children, from the mid-teens all the way into the mid-80s and 90s, with the average score being right in the middle on a scale of 0 to 100, about at 50, with a nice distribution of scores. So they were not all bunched together at one end of the scale, or the good end of the scale, or the bad end of the scale. So in other words, there are no ceiling or floor effects. There's a wide distribution. We then tested its validity using something called the Construct Validity. What we mean by this is that we hypothesize that if this measure is performing in the way it's intended, then we should be able to show that children who are more severely involved should score lower than children who are less severely involved. And remember, the CP Child is intended only for non-ambulant kids with cerebral palsy. That's GMS's level 4 and 5. So we tested in all cerebral palsy, and we found that between 1s, 2s, and 3s, there was very little difference, because it wasn't intended to show differences and really didn't apply to this population. But between GMS's levels 3, 4, and 5, there was a significant drop in scores that was very significant, even between levels 4 and 5, just as we hypothesized. We also then compared it to other existing outcome measures like the Child Health Questionnaire. That's a popular generic health-related quality of life measure used for children using the parental version. About a third of these, the parents were upset that these questions were just inappropriate or too high level for their children, and therefore they couldn't answer those questions, which means they couldn't even generate a score. But when they could be analyzed, there was the kind of correlations you would expect between the CP Child scores and the physical health scores and the psychosocial health scores of the CHQ. We also compared it to the PD, which is another pediatric generic health status measure. There's a PD call for cerebral palsy as well. And we found that the CP Child, the individual domains, had good correlations with the appropriate domains of the PD questionnaire, which is what this table demonstrates. However, when we look at the PED scores, you can see that in the same group of patients, they're all bunched up at the lower end of the scale. In other words, most of them are at a score very poorly on the scale, so they've got what are called floor effects. It's unable to tease this population apart because there are lots of items in this questionnaire that are not appropriate for this particular population. Remember, I told you about the Health Utilities Index. The Health Utilities Index is a generic measure of the health status of health or quality of life of an individual that generates a score of 0 to 1, where 1 is considered perfect health and 0 is considered a quality of life equivalent to being dead. And the way this is done is based on asking whoever completes the questionnaire a series of questions about the health of themselves or their child, on their vision, their hearing, their mobility, in various dimensions. And they just, document how their health status in each of those domains. And prior research has checked with a societal perspective that if you live with a hearing impairment or a visual impairment, how would society deem their quality of life on a scale of 0 to 1? And based on that societal perspective, that's applied to how the parents have completed this questionnaire, and it generates a score from 0 to 1. Okay, so we wanted to compare the CP Child on the x-axis with the HUE, the Health Utilities Index, which is very much used for health economic evaluations as an important outcome measure. And we were very pleased to see that there was a positive correlation. As the CP Child scores increased, the HUE scores also increased. Fantastic. However, the HUE also has the ability to score somebody below 0 and give them a negative score. And you can see that 2/3 of our population of children had a score that was below 0. In other words, from a societal perspective, these children like Jill, are believed to have a quality of life of worse than death. In other words, people are saying, I would rather be dead than live like Jill. And I can tell you, that's not what Jill believes. That's not what her mother or uncle believes. She has a quality of life. She can be a happy person. She may have pain today, but we can manage that and give her a quality of life. And so we have to be careful in how we impose a societal perspective of quality of life on people with disabilities. And this is the disability paradox. You can have a high quality of life against all odds, that the sum of a patient's problems does not equal to their perception or their parents' perception of their well-being. And that function or functional deficits is not or does not necessarily correlate with quality of life. So what? How does a CP Child help us? And at this point, I want to remind you, CP Child is not a measure of quality of life. It is a measure of things that parents have said to us are important for their child and for them, that if we could make improvements on them, will help their child. It's not about quality of life, it's about things that are important to them, their priorities. At best, it's their health-related quality of life. So to test this further, we said, all right, if it's functioning well, what are the impact of the different health conditions on the CP Child scores? And we tested a large sample of patients who had feeding difficulties, hip displacements of varying amounts, whether they had seizure disorders that were either no seizures or seizures that were controlled or poorly controlled, severe tone with baclofen pumps, whether they had spinal deformities or not. And we found that the higher the GMSTS level, the worse their scores. If they were fed by a GJ tube, they scored worse than if they fed by a G tube, and they scored worse if they were fed by a G tube than if they were fed orally. The increasing hip pathology was associated with poorer scores on the CP Child. If the seizures were poorly controlled, they were scored worse than if the seizures were better controlled. So just behaving in the way we would expect it to behave. And the multivariate analysis, these were things that were important. The GMSTS level, that's 5 scores lower than 4, increasing hip pathology, the method of feeding, and the seizure status. But that only explained about 43% of the various CP Child scores, which means other factors other than these comorbid conditions also influence the CP Child scores. But this told us that comorbid conditions or health problems do have an impact on the health status and well-being and caregiving of children with severe cerebral palsy as measured by the CP Child, and validates that expanded definition of CP, which includes all of those things within that definition when it was published in 2006. So this work helped us conclude that the CP Child was a reliable and valid condition-specific measure of some of the functional limitations, ease of caregiving, and health status and well-being based on a caregiver's perspective of children with severe non-ambulatory cerebral palsy. But it's important then also to answer an important question is, when there is no change, it's reliable and gives you the same answer if it's administered 2 times. But the corollary of that is when there is a change, either good or bad, is it capable of being sensitive to change? Can it pick up a change? And that is the property of sensitivity to change or responsiveness. We tested this in a group of children with severe cerebral palsy who were candidates for hip reconstructive surgery because they had increasing hip displacement, 20 of whom who had surgery and 20 of whom who, because of the wait list or because the parents had deferred surgery, were in a control group. And we measured the CP Child at baseline at 12 months later, and also the radiographic measures. And we found that at baseline, their CP Child scores were identical for the total score. For each of the domains, they were also identical on a scale from 0 to 100 for each of the domains, except in the domain of comfort and emotions, where the children who underwent surgery had poorer pain scores than the children who had control. We were doing the operation of the right kids, if you will. But this allowed us to compare these two groups at 12 months. We looked at the radiographic outcomes. These are the technical outcomes before and after the operation. So they were displaced by about 50% before the operation, and they were normalized after the operation. So our operations were doing the technical objectives. And here's the change that we saw from baseline to 12 months. So each of these is either the improvement or the change in scores from their baseline score for those who had the operation and those who were in the control group. So in the operative group, the total score improved by 12.4 percentage points from 0 to 100, that is, whereas the control group really had no change. The biggest improvements were in total score, in personal care and ADLs, in positioning, transfers and mobility, and in comfort and emotions. Whereas in the control group, there were little or no changes, which at least over 12 months suggests that while they had not had any surgery, they hadn't deteriorated or made any improvements either. Again, showing us two things, that it is very reliable when things don't change, and it's sensitive to change when things do change. And here graphically is the same information we're showing from baseline to 12 months in the blue group, which are the cases who underwent the surgery, and the control group who didn't. The improvements, they started off similar, and the improvements that they made at 12 months compared to the control group for personal care and activities of daily living, for positioning, transfers and mobility, for comfort, emotions and behavior, and the statistical measurements of the responsiveness, the standardized response means, and effect sizes were very respectable, almost 1 or 1.3 standard deviations. That's really quite high. We did similar work for patients undergoing spinal interventions with the HARM study group, which is a North American multi-center study on 271 children. The bottom line being we found very similar sensitivity to change for those who underwent spinal operations compared to the non-operative group, who were the control group. But the changes were more modest than the hip intervention group. And that's not surprising, because many of the kids who were undergoing operation with their scoliosis were being done for prophylactic reasons. Their operations were being done to prevent bad things from happening in the future. And so for some of them who didn't have any symptoms, you wouldn't expect their CP Child score to improve, but for whom they did have problems, those CP Child scores seem to improve in these domains, in the total score, personal care, ADLs, positioning, transfer, mobility, comfort, emotions, and overall quality of life. Again, in the areas where you'd expect to see improvements, not so much in communication or in health issues. Okay, and here the effect sizes were about half of a standard deviation. So we conclude that the CP Child is sensitive to change or responsive, and therefore a good outcome measure to use for clinical trials looking at hip reconstructive surgery or spinal surgery. We've done similar work for intrathecal baclofen, now for deep brain stimulation, and for other interventions for this population, including seizure management. The CP Child is being translated now into over 20 languages around the world, and with cultural adaptations and validation in those languages. This allows us now to do multi-center international prospective research studies to compare different approaches for these populations. So the CP Hip Outcomes Project is funded by CIHR, which is like our NIH in Canada. We've enrolled 700 patients in 28 centers around the world in 11 countries, comparing natural history to kids with hip displacement who are undergoing serial Botox injections compared to soft tissue surgery alone, compared to bony reconstructive surgery, compared to salvage operations, to try and answer the question, which of these strategies compared to natural history is the most efficient and effective in terms of having a positive impact on their health-related quality of life. We're doing the same for spinal interventions with the HARM study group here in North America. There are groups looking at intrathecal baclofen, GI interventions like Nissen's fundoplications versus GJ tubes, and for seizure management, and another group looking at deep brain stimulation. So to summarize, the effectiveness of our interventions really should be judged using meaningful outcome measures that reflect the goals and expectations of individual patients, and therefore they should be patient, or when we can't ask the patient, they should be parent reported. These outcome measures must be relevant and meaningful and aligned with the goals of the patients or their parents. They need to be reliable, valid, responsive, and sensitive to change. Can we measure important change for this population? I think we can. Are we making a difference that matters? I think we now have the means to find out, and the clinical trials that we're doing are some examples of the work that is trying to do that. I want to acknowledge our sources of funding that have fueled a lot of this work. The many members of my research team who contributed to the development and the validation of the CP Child in Canada and elsewhere. The CHOP International Study Team from around the world looking at the interventions for hip displacement for cerebral palsy, for severe cerebral palsy. And this is our website that summarizes some of our work. And I'm going to stop right there.
Thank you, Dr. Narayan. I am going to take over sharing so I can moderate the questions. We have a few minutes for a couple of questions here. So the first question is, what is the MCID for CP child? Will you have percentiles at age and GMFCS? How about tablet for administering and scoring?
Thank you for those excellent questions. So the minimal clinical detectable difference is 4 points, right? That is anything less than 4 points is noise. That's the mean absolute difference that we found in our retest reliability. So it has to be anything more than 4 points for it to be a real difference. However, that's different from what is the minimal clinically significant or important difference. And that is query subjective. And there are many ways to do it. And the way we have tried to do it is to ask parents, during our responsiveness studies, to separately tell us whether they think their child has improved in those domains that are captured by the CP child, whether they've deteriorated a lot, deteriorated a little bit, they've perceived no change, improved a little bit, or improved a lot, and try to correlate that with the change or lack of change in the CP child scores. The bottom line is it comes to around 5 to 6 points, percentage points. I think if you want to be safe, a 6 percentage point difference is meaningful, and that's what you should be powering your studies to look for a meaningful difference. Will you have percentiles at age and GMFCS? Well, while GMFCS level has a significant impact on the CP child score, so on average, the GMFCS level 5s score about 45 on a score of 0 to 100, with a wide distribution from the single digits to the mid 80s. And GMFCS 4 on average score in the upper 50s, so they're quite separate, but overlap quite a bit with level 5s from the mid-teens to the mid-90s or low 90s. So the CP child cannot distinguish a level 4 from a level 5. If it could, we just use the GMFCS level. In other words, there's plenty of overlap. The average scores are very different, but there's plenty of overlap that it doesn't distinguish it. Okay. Age, there's no correlation. We've looked at this, that age did not result in a decreasing CP child score at all, or an increasing CP child score. And we looked at the age from the age of 4 all the way up to 19. So there really is no sense in generating a percentile score. And unlike for the goal, which we'll talk about in the next talk, because this is a measure of an individual parent's perception of how easy or difficult it is to look after their child, that child's health status at any given time, and their parents' perception of their well-being, and all those multiple domains, generating a percentile, in other words, ranking a child to compare that child with another child, I don't think is appropriate. The child should only be compared with him or herself from time 1 to time 2. Or from previously to past. So the same child with the same sets of conditions, same amount of pain, 2 different families might rate that child very differently. So we shouldn't be really comparing one child against another child. So percentiles, I think, are meaningless. It is that child relative to him or herself at any given time. Does that make sense? That's a very important distinction. And I'm happy to talk more about that.
Perhaps just one more question. Can we use the CP child outcome measure for PT-related intervention, and where do we get this outcome measure?
Okay. So the CP child was intended for any intervention for children like Jill. So children who function at GMSC level 4 or 5. Now, it depends on what the intended goal of your PT intervention is. If it's just to improve the range of motion, you got to yourself, well, what is that purpose of improve range of motion? If it's to improve or make caregiving easier, then use the CP child. So yes, so it really depends on what the goals are, and it's for level 4s and 5s. answering the previous question about, so we have an electronic version of the CP Child. It's available on our website. You have to register for a license, which is free for academic or clinical purposes. And there is an electronic version that we use REDCap for, but we're also generating a more sophisticated version that can generate summary scores. And I'm going to talk a little bit more about in our second talk. And I'm conscious that I took more time than I intended for this talk. But in the second talk, we'll have more time and we can get back to this because it applies to both the measures.
Thank you so much, Nick.